Thanks all for joining us. This is first of the Neurotology Eastern Region Virtual Education Series of 2022. And we are very lucky to have Dr. Matthew Bush joining us from the University of Kentucky to talk about facial nerve disorders. Thanks so much for taking the time, and I'll turn it over to you.
Thanks, Dr. Raymond. Can you hear me okay?
Hearing you great.
Great, thank you. So I am privileged and honored to talk with you and present a little bit about facial nerve disorders. This is a huge topic in neurotology. And so in some ways, I'll scratch the surface on a number of topics, but not really do a deep dive or deep dissection on any one of these main topics. But I'm hopeful this will generate some thought and further investigation research on your part. Certainly feel free to reach out to me at any point in time subsequent to this presentation if you do have questions about anything. These are my disclosures. I have some research funding from Advanced Bionics for research that's unrelated to any of the presentation today. I also have been a surgical advisory board member for MED-EL and also have been an educational consultant for Stryker. Again, there are no conflicts with this presentation and those relationships. I won't be talking about any off-label treatment of patients related to the presentation or underlying research. And I am an NIH-funded researcher funded by the NIDCD, and those are the grant mechanisms for our research funding. I would like to send you happy, healthy, Happy New Year greetings from the Commonwealth of Kentucky. Colonel Sanders is, certainly a figurehead. And a lot of people think of Kentucky, they think of Colonel Sanders, who actually is not from Kentucky originally, is from southern Indiana, but made his claim to fame in the chicken empire through a very small restaurant in Corbin, Kentucky. But there's more to Kentucky than just fried chicken. And these are some Kentucky notables. The University of Kentucky basketball team is a figurehead and a pillar to the community in the sports world in Kentucky. I would like to posit that our women's volleyball team is amazing and one of the best team of athletes I've ever seen, and they are the reigning national champions from last year's volleyball season. Abraham Lincoln, our 16th president of the United States, was also hails from Kentucky, and Kentucky is also the birthplace of some pretty amazing equestrian royalty. American Pharoah and Justify are just a few of those royalty who have retired from their racing careers and have been put to pasture just a few short miles away from where I'm giving this presentation. And then, of course, Kentucky is the birthplace of bourbon, the corn-based whiskey that has been made Kentucky famous and is a big part of the industry of tourism within the state of Kentucky. So not all whiskey is bourbon, but all bourbon is whiskey. So I am a neurotologist and lateral cranial-based surgeon from the University of Kentucky. And I've been here at the University of Kentucky on faculty for about 10 years. I grew up in West Virginia, did my medical school training at Marshall University, and came to the University of Kentucky for my otolaryngology residency, and then completed a year of bench research fellowship, as well as a otology, neurotology, and cranial-based surgery fellowship at The Ohio State University. This is the outline for our presentation as we'll work through facial nerve disorders. We'll just touch briefly on some things about development, anatomic segments, and functional components, and really spend most of our time working through different facial nerve disorders. Well, the facial nerve is the mother of all cranial nerves, so says the lateral skull-based surgeon, but this nerve is very complex in its composition. 10,000 fibers, 7,000 of which are involved in the mimetic muscles, or the muscles of facial expression. 3,000 nerve fibers are contributing to innervation of a variety of different things, which include the submandibular and lacrimal glands, the sensory fibers to the posterior external auditory canal, and sensory fibers for taste through the chorda tympani. Developmentally, the facial nerve is in a vulnerable location at the lateral base of the skull and can be prone to injury based on its early appearance at a more lateral and superficial position in infants. During the course of craniofacial development, the facial nerve falls into more of a medial and deeper position within the skull base. However, it's based on its development, it has the potential to be injured in neonates. There are a variety of different anatomic anomalies that can occur with the facial nerve, especially within the tympanic segment. There can be bifurcation of the facial nerve with a segment of the nerve anterior to the oval window. The facial nerve can also course directly over the oval window. It can travel through the stapedial arch. It can travel inferior to the oval window, directly inferior to the geniculate ganglion over the promontory, and even over the superior aspect of the lateral semicircular canal. All of these things are potentially harrowing situations for the temporal bone surgeon, but careful use of smart and cautious dissection skills, as well as facial nerve monitoring equipment, can help the otologic surgeon be aware of anomalies of the facial nerve, especially within the tympanic segment. So some clues and cues to abnormal anomalies of the facial nerve: being aware at any given moment and having a high level of suspicion for something that looks nerve-like and could be the facial nerve is important. Be aware that the nerve could bifurcate or trifurcate potentially, and so being very cautious not to be aggressive about bony dissection around the nerve. In the setting of congenital aural atresia, the nerve can be shortened, and have even an absent vertical segment coursing inferior to the round window that can make potential work in the middle ear or in the atresia repair complicated. Be cautious of a very thick chorda tympani in a congenital ear, because that actually may be carrying motor fibers in that segment. Any surgeon of the middle ear is aware of dehiscence of the facial nerve, and this occurs within the horizontal segment due to failure of ossification centers to meet and to fuse. This might be noticed in children in the setting of facial paralysis that occurs during acute otitis media. There may be some inflammatory process that occur with the acute otitis media that may lead to facial paralysis. Often can be treated by myringotomy and ear tube placement with potential culturing of the middle ear contents. Facial fallopian canal dehiscence can occur in 25 up to 60% of ears, and it's not uncommon to have more than one area involved. The most common area for this to be involved is the tympanic segment of the facial nerve just above the oval window. An additional 10% of patients with dehiscence may have this in the mastoid segment, possibly within the facial recess. This can be noted during cochlear implantation. There are classifications of the nerve injury that actually occurs on a transsectional level and what occurs within the nerve itself. The Sunderland nerve injury classification is a classic one that's used. We won't spend much time here, but this is important to understand that this type of injury may have a variable impact on the prognosis and the recovery. In the setting of Wallerian degeneration of the distal segment, there is concern for what may occur with synkinesis and other things. So this classification is one that is important to commit to memory, not only for testing purposes for those of you that are residents or fellows for in-service or board examinations, but also being aware of being able to interpret electrophysiologic information, trying to understand what's happening on a cellular level. On a clinical aspect of things, the House-Brackmann grading system is the most commonly used system. Also is important to commit to memory and understanding the grading system, from grade 1 being normal, grade 6 being complete loss of function with no evidence of movement. And a clinically very important number to remember is grade 4, and this is the situation where there is incomplete eye closure and there is the potential risk of exposure keratitis. So one must be cautious and careful to protect the eye in the setting of facial paralysis, especially for those that may be 4, 5, or 6. Frequent examination of patients that may have had a facial nerve injury, such as in the setting of trauma, is warranted because a patient may have, upon initial presentation, a grade 2 or grade 3 injury, but that may progress to a 5 or 6 within a short period of time. And so there is a value for regular monitoring of the facial nerve function and recording that dysfunction using this grading system. There's a wide range of different mechanisms on diagnostic tools to evaluate the facial nerve and the physiology of surrounding cranial nerves. It is often the situation in patients that have a facial nerve injury may also have some degree of hearing loss as well, depending on the type of pathology. So an audiogram may be a part of the management and evaluation of a patient with facial nerve injury. There's a variety of other tests, such as VNG or ENG or stapedial reflexes, that may be also performed to evaluate other cranial nerve 8 function and cranial nerve 7 function. Topographical studies are a bit more historical than they are practical, at least in my practice. Electrophysiologic tests have taken the priority in diagnostic evaluation. The two specific tests are the ENOG and the EMG tests, which provide objective assessments of facial nerve paralysis. The important thing to remember is that electrophysiologic testing is really only indicated in patients that have a House-Brackmann grade 6 injury and weakness of the nerve, and is not necessary to perform this testing in patients with 1 through 5 on the House-Brackmann scale. The nerve excitability test and the maximal stimulation tests are more subjective tests and certainly can be performed, but due to the quantitative nature of ENOG and EMG, we tend to prefer those tests. And then, of course, imaging studies are important in the evaluation of the facial nerve. When we think of what type of study to perform on what type of facial nerve pathology, think of it in this terminology, that a CT scan is vital to assess intratemporal course of the nerve, that a process that may have injured the nerve within the temporal bone is valuable to assess CT scan imaging. And that may be in the setting of trauma, facial nerve impingement, perhaps from a bony spicule or bone fragment in a temporal bone trauma, and fracture is important to obtain CT scan imaging. Intratemporal facial nerve tumors are also evaluated with a CT scan, as well as complications of ear disease, such as cholesteatomas or other types of chronic inflammatory conditions or neoplastic processes within the temporal bone. That CT scan is going to be helpful to help us assess the bony anatomy around the nerve. Now, an MRI is also vital to assess for intracranial and extratemporal disease, as well as to assess for enhancement and the behavior of the nerve within the fallopian canal. So enhancement of the nerve proximal to the labyrinthine segment is uncommon and might indicate some type of neoplastic or inflammatory condition. And then extratemporal disease, perhaps within the parotid, could be evaluated also through MRI. In many situations, both a CT scan and an MRI is performed to obtain adequate imaging and assessment of the course of the facial nerve. So with that, let's jump into some of the different pathologies and kind of how we go into evaluating disorders of the facial nerve. Of course, with any clinical scenario, a careful history is critical. And so with facial nerve injuries and facial nerve disorders, it is important to evaluate the onset of weakness and determine the degree of weakness. It's important to know if patients are also experiencing pain, could represent a neoplastic process or some type of inflammatory condition such as malignant otitis externa. Are other cranial nerves involved? That's an important question to ask. Is this a recurrent condition? Such could be the case with Melkerson-Rosenthal syndrome or with the cerebellopontine angle tumor. Additionally, it's important to know if this is a bilateral condition. And if a bilateral condition is involved, it might be a process such as the Guillain-Barré or perhaps congenital condition. Furthermore, trauma can cause bilateral facial nerve paralysis, as can sarcoidosis and Lyme disease. So being aware of these other causes that can lead to bilateral facial nerve paralysis. Let's talk first of all specifically about Bell's palsy. There's a minimum diagnostic criteria that's important to ensure is the case before labeling this as Bell's palsy. An acute onset of unilateral facial nerve palsy is certainly necessary for a diagnosis of Bell's palsy. Sudden onset is important. That's a progress to complete paralysis within 3 to 7 days. Also, this is a diagnosis of exclusion. So in the event of negative imaging or other conditions or other abnormal findings, Bell's palsy can be made as the diagnosis. Additionally, patients with Bell's palsy may experience numbness, pain of the ear, face, or tongue. They may have a viral prodrome that may have preceded this onset of facial weakness. There may be a family history. Additionally, there may be a loss of ipsilateral tearing or salivary flow, and perhaps even hyperacusis or a decrease or loss of the stapedial reflex. This condition is felt to be caused by viral reactivation within the geniculate ganglion with the herpes simplex type 1. This first was described by McCormick in 1972, and the HSV fragments have been identified from perineural fluid, and there's also animal models that further support this finding. And the pathophysiology involves facial nerve demyelination and inflammation and swelling that can lead then to vascular compromise within the fallopian canal. There are risk factors for Bell's palsy. Diabetes mellitus is one of these potential risk factors. The exact risk is undetermined. However, there is some evidence that links diabetes with Bell's palsy. There may be forthcoming research that may cast doubt on that, but one needs to be aware, especially when vasculopathies are part of the pathophysiology of diabetes. There's also been some research to support a correlation between Bell's palsy and pregnancy, with a 3 times higher incidence in pregnant patients, primarily occurring within the 3rd trimester. Those with preeclampsia may be even more at risk than others without preeclampsia. Peterson's landmark study gives us some information about the prognosis and just some management strategies related to Bell's palsy. So this facial nerve study was performed with over 1,000 patients that had idiopathic spontaneous peripheral palsy that was followed a spontaneous course without treatment, and looking at the timing of complete recovery. And you can see on the course of over 6 months, 71% of these patients got back to House-Brackman grade 1 or normal facial nerve function. Looking at those that presented with incomplete paralysis from this research, that those with grade 1 through 5, 94% of those patients recovered completely, whereas 6% remained with some degree of residual weakness. Those with the complete paralysis, as mentioned on the previous slide, within 6 months, 71% returned to completely normal function, whereas 13% had mild residual symptoms, whereas 16% would be fair to poor prognosis. And those are the patients that may benefit from aggressive medical or surgical therapy based on their work. Patients that were greater than 60 years of age were more likely to have reduced return of function. And then when recovery was delayed greater than three months, all of those patients experienced sequelae, such as ocular problems with exposure keratitis or potentially synkinesis. We're about due for an update to guidelines to Bell's palsy. This is the Academy guidelines from 2013. And based on some of the strong recommendations, I just wanted to draw your attention that there are strong recommendations that clinicians should assess the patients with a history and physical exam to exclude identifiable causes associated with acute unilateral facial paresis or paralysis. That may seem like common sense, but the evidence really supports it in the value of very careful and accurate history and physical. Furthermore, clinicians should prescribe oral steroids within 72 hours of symptom onset in patients that are 16 years or older. The sooner the better is obviously the primary focus in that situation. Clinicians should not prescribe oral antiviral therapy alone for patients with new onset Bell's palsy. And clinicians should implement eye protection for new onset patients with impaired eye closure. And those might be patients that are a grade 3 because of a fear of progression. So at least the 3s should be closely monitored, but certainly grade 4, 5, and 6 should have eye precautions and eye care recommended. You can see some of the other recommendations that don't have quite the strength and the evidence base that the 4 that I've mentioned here listed below, as well as some of the options, as well as even the no recommendation. Notice that in the no recommendation category include surgical decompression for patients with Bell's palsy, acupuncture, physical therapy, and by reading these 3 together, I do not have any intention of linking all 3 of these together. However, just be aware of that this is a challenging group of patients to study, and the evidence base that supports these respective therapies just could not be fully supported by this guidelines task force in 2013. So, when is further workup indicated in Bell's palsy? So these are some things to consider. When there has been some improvement or recovery in 4 to 6 months, for those patients that may have complete paralysis. If incomplete recovery, then considering doing EMG, that can be performed to document the status of the nerve and what type of action potentials one can identify, as well as to give patients information on prognosis. Imaging can be useful. A contrasted MRI is mentioned here, according to Peterson's work. The absence of improvement after 4 to 6 months after onset, recurrent ipsilateral paralysis, or progressive paralysis beyond 3 months, or the presence of facial twitching. What about surgical decompression in the setting of facial nerve injury or facial nerve weakness, especially such as Bell's palsy? The group in Iowa, under the direction of Dr. Gantz, performed a landmark study that was published in 1999 that addressed this. In patients that had greater than 90% neural degeneration within 2 weeks of onset, there was a concern that 50% of these patients may have residual weakness and synkinesis. And so when that condition above is present and an EMG is performed with absence of motor unit action potentials, there was an indication in their study to perform surgical decompression at the meatal foramen, and the labyrinthine segment and over the geniculate ganglion. And those patients that received the surgical decompression in that met that criteria had 91% recovery to House-Brackman grade 1 or 2 at 7 months, whereas a similar group of patients only had 42% recovery to that degree of House-Brackman 1 or 2 when treated with steroids alone. So the hearing status in this particular situation, in this study, dictated which surgical approach was needed. A middle fossa was necessary for those with functional and aidable hearing, whereas a translabyrinthine approach could be performed in those patients that had anacusis or very poor non-functional or non-aidable hearing. This is a treatment algorithm of how they considered management of these patients, but those early onset, day 0 to 3, of course, as soon as possible, initiate prednisone treatment and steroid management and very close follow-up. Between days 3 and 14 is when the enog was performed, and the degree of degeneration determined which direction they pursue or followed then in the study. Those, again, as mentioned before, with greater than 90% degeneration went on to have the decompression. Those with less than 90% were maintained on prednisone and then followed up with an additional enog after that. And then those beyond 14 days, there was follow-up planned for those patients as they were outside of a window of time to be able to perform the decompression. Now let's talk about Ramsay-Hunt syndrome. This is the second most common etiology behind Bell's palsy for facial nerve insult or injury. This is similarly a reactivation in the geniculate ganglion. However, we're talking about varicella zoster virus here. In this situation, patients present with facial paralysis with hearing loss plus or minus vertigo. The facial nerve not being involved in that above mentioned constellation of symptoms, we might refer to herpes zoster oticus. The majority of patients have some type of vesicular lesions that occur around the ear or perhaps within the conchoid bowl. However, it's also possible to see oral lesions at the same time. Compared to Bell's palsy, the pathophysiology indicates that this is a more diffuse neuritis, unfortunately leading to a worse prognosis. And so there is a poor prognosis with only 10 to 50% having a complete recovery of function. Other cranial nerves can be involved in this situation as well, particularly the trigeminal nerve or cranial nerve 5. Lyme disease is a tick-borne disease that is endemic to certain areas of the northeastern United States, as well as Central Europe, Scandinavia, and Canada. It is present clinically with a target-like rash, a bullseye-type rash, and other symptoms that can accompany Lyme disease include arthritis, carditis, and encephalitis. A minority of patients can present with facial nerve dysfunction. However, the prognosis in those patients is excellent. So it is, however, possible to cause bilateral facial nerve paralysis. So you need to be aware of this and might be a part of a laboratory workup in patients that present with facial nerve paralysis, especially in those endemic areas. So it's important to identify this early because the disease is very treatable and curable with antibiotics, which is usually a 4-week course of antibiotics such as doxycycline. Melkerson-Rosenthal syndrome is known as recurrent alternating facial palsy. These patients also have recurrent labial periorbital facial edema, as well as fissured tongue or lingua plicata. This is associated with increased ACE levels during these episodes, and this is often accompanied by a positive family history. Now let's talk about traumatic injuries. Temporal bone trauma can cause injury to the facial nerve in a variety of different locations. It requires a great amount of force to lead to a temporal bone fracture. 1,800 pounds per square inch is required to fracture a temporal bone. And the fractures within the temporal bone typically occur at the weakest points, and that can be along foramina or perhaps canals such as the fallopian canal. Historically, facial nerve or temporal bone trauma was characterized and classified according to a longitudinal or transverse pattern. However, a more modern classification scheme is based on the status of the Otic capsule, and does the fracture traverse or violate the Otic capsule or not, because that has very important functional implications. Otic capsule disrupting fractures are often very similar in its pattern to transverse fractures, and Otic capsule sparing fractures are often similar in pattern to the longitudinal historically. However, in our institution, we prefer to use the Otic capsule sparing or disrupting classification as describing these injuries. Facial nerve involvement with temporal bone trauma occurs about 7% of the time with temporal bone fractures, and of those 7%, about 25% are complete paralysis. So when is an important issue of when complete paralysis develops. If it's an immediate facial paralysis, then it might change what is done clinically versus a delayed onset, and that delayed onset may be different than delayed diagnosis. Perhaps a trauma patient comes into the emergency department and is a part of a multi-system trauma workup with scans and a variety of exams. It might be a delayed fashion that it is actually documented the facial nerve function, and perhaps an otolaryngologist is consulted. So one needs to be aware of exactly when the facial nerve injury is first documented, and if there was normal facial nerve function present on the time of admission is a really important piece of documentation and detective work to look into. So where do temporal bone fractures injure the facial nerve? Well, it can be a variety of different locations. The perigeniculate and labyrinthine segments are often involved. Around the geniculate area, the facial nerve is tethered with the greater superficial petrosal nerve, headed anteriorly in the tympanic segment, headed posteriorly. So in the situation of longitudinal fractures, the most common mechanism of injury is with a hematoma within the labyrinthine or within the fallopian canal. However, bony impingement from bone fragments or even transection is possible. Now, with transverse fractures, which are often, as I mentioned before, more likely to be Otic capsule disrupting fractures, in those situations you may see a transection. That's the most common mechanism of injury. Here's a schematic kind of giving a algorithm for how to manage facial nerve injuries. So if I'll go to the right side of the algorithm first, if after a facial nerve injury occurs with trauma and it's a delayed onset, they were normal at initial presentation, then all that is indicated is observation. Many people would recommend use of steroids, but careful observation, looking for complications of exposure keratitis is important. And steroids may be recommended, but are not absolutely critical. In facial nerve injuries that are acute onset, if it's an incomplete paralysis, then monitor for progression. If it becomes complete, then treatment as described before with steroids and eye care is indicated. If it remains incomplete paralysis, then again, basing the treatment based on the severity of the weakness. For those that have complete paralysis at presentation, serial enogs can be helpful. And again, when you're dealing with greater than 95% in this particular schematic, in the Gans paper, more than 90% degeneration within 14 days, the facial nerve exploration has a role. With less than 95% degeneration, then observation is often recommended. It is important to obtain high-resolution, non-contrasted CT scan of the temporal bone to investigate the course of the facial nerve in this situation. Iatrogenic facial nerve trauma is possible in the setting of birth trauma. Forceps deliveries or prolonged or complicated deliveries can result in unilateral complete paralysis. There's a 90% or more recovery rate. It is possible to do electrophysiologic testing in the infant, but nevertheless, that is something to consider. In Mobius syndrome, which is more of a congenital form of facial weakness, ENOG or EMG may be reduced or absent at birth with no progression or recovery. Otherwise, considering some of the salient things to address in facial nerve trauma, in the setting of middle ear or mastoid surgery, the facial nerve could be injured in a variety of different locations. For those that are doing middle ear surgery, the tympanic segment just above the oval window is the most common location for injury. The most common area in the mastoid for injury is at the second genu, just before the downward turn to the descending segment of the facial nerve. The nerve could be injured by direct manipulation or perhaps through the drill itself during a mastoidectomy or during a facial recess approach. It's important to recognize this intraoperatively or upon anesthesia reversal. In the situation where the surgeon has identified intraoperatively a facial nerve injury, it's often a good idea to phone and contact a colleague to join you in the operating room and just inspect the wound and confirm, what has occurred, confirm the degree of the injury, just add some peace of mind that one's career is not flashing before their eyes. If the injury is less than 50% thickness of the nerve, which can be difficult to assess, but you may need to further expose the nerve proximally and distally to ensure that you know how much of the nerve might be involved. But if it's less than 50%, primarily repairing the nerve is indicated. For greater than 50% injury, it probably would be best to resect that section and then primarily reanastomose the section by taking the tension off of the nerve or using an interposition graft, such as one that could come from the greater auricular nerve or from the sural nerve. Cable grafting using a variety of different nerves are available, and so it all depends on how much length is needed. The greater auricular nerve is one commonly used by otologists because of the proximity to the surgical field within the lateral skull base. But you can get up to 10 centimeters of the greater auricular nerve for cable grafting. The sural nerve provides a much longer length and a greater number of neural fascicles, but you can also utilize the medial antebrachial cutaneous nerve, which can give you an adequate length for 15 centimeters, but even give a branching pattern for those that have extratemporal pathology. Nerve substitution is also should be within the armamentarium of the skull base surgeon and the facial nerve surgeon. Hypoglossal facial anastomosis can improve the tone and symmetry in the majority of patients, more so in the mid-face and the lower face than the upper face. This is used typically in that complete transection or greater than 50% transection situation. Cross-face grafting also can be performed. It's much less controversial. It has been controversial in the past, but is much less controversial now. There's a number of other facial nerve rehabilitation options that the surgeon can consider. But for the sake of time, we'll move on to other pathologies. Considering neoplasms, this is an important thing to consider in the differential diagnosis. In this situation, a progression of facial paralysis of greater than 3 weeks duration should raise one's suspicion of a neoplastic process. Furthermore, no evidence of recovery after 4 to 6 months should raise some concern for a neoplastic process. The presence of facial twitching is also an independent risk factor for a neoplastic process. Ipsilateral recurrence after recovery of the nerve. And then on EMG studies, the evidence of simultaneous fibrillation potentials and polyphasic potentials, again, might make you concerned for a neoplastic process. Well, one of the most common neoplastic processes that we would see within the lateral skull base, at least within the an intratemporal or intracranial, would be a facial nerve schwannoma. These schwannomas can occur along any portion of the facial nerve, and in most situations, multiple segments may be involved. The tympanic segment is the most commonly involved segment with facial schwannomas. The symptoms very much do depend on the location of the affected segment. These do not produce facial weakness until tumors are larger. So this is in opposition to facial hemangiomas, which we'll talk about next. And these intratemporal lesions have the possibility of neural entrapment, more likely to result in facial paralysis. So that tight, dense, bony fallopian canal can prevent the nerve from expansion, and so growth in that area may expand the fallopian canal, but may lead to facial nerve injury and weakness based on that kind of compression. Here's some representative imaging here. You can see on an MRI scan with contrast on the top right, an enhancing lesion, kind of almost an ice cream cone appearance as demonstrated here. And it looks similar to a vestibular schwannoma in that setting, but looking for other clues and cues to what might be involved, such as some expansion of the fallopian canal, as seen in the bottom right, within the mastoid segment, or within some type of bulging in the tympanic segment. So the things that you might see on imaging is that erosion of the anterior superior internal auditory canal, erosion or expansion of the labyrinthine facial nerve, and then distal tumors expanding that fallopian canal, and even can see what's called beads on a string of these enlarged areas of the fallopian canal that are separated by segments of normal canal. Here's an example of enhancement of the facial nerve, not only within the internal auditory canal on the right side, but also enhancement of the perigeniculate region shown by that white arrow. You may see this as described before, some expansion of the perigeniculate region, giving some clue to a facial schwannoma. Similar to vestibular schwannomas, these lesions present very similar histopathologically with Antoni A or densely packed spindle shaped cell regions, as well as Antoni B or loose tissue arrangement with cyst formation. There are treatment options for vestibular schwannomas and facial nerve schwannomas that may be one and the same, which include observation, radiosurgery, and surgery. In the setting of facial nerve schwannomas, we consider decompression and debulking as options, not just resection alone. Often we reserve resection of facial nerve schwannomas for those with greater than Hallsbrackman grade 3. There is controversy regarding the outcomes that have occurred with debulking. There is a fear with debulking that you might have a complete loss of function, but there are many studies that have identified that it is possible to debulk some facial schwannomas and maintain facial function. In dealing with a facial schwannoma, you have to be prepared to resect the facial nerve anywhere from the pons all the way to the parotid, and that may require quite an extensive cable nerve graft, which might require a sural nerve in that situation. Facial nerve hemangiomas present slightly differently, although may be in a similar location to facial nerve schwannomas. These lesions occur around the geniculate ganglion most commonly, and these lesions often present with calcifications. You can see on the CT scan to the top right these whitish calcifications within the geniculate ganglion region, and that is a representative image from a hemangioma. These are vascular malformations that may be S100 positive, but they're not true hemangiomas. They're irregular dilated vessels that lack internal elastic lamina. Different than facial schwannomas, the facial nerve paralysis is out of proportion to the size of the lesion. So it's not too uncommon to have a patient with a small tumor, as demonstrated by the CAT scan to the top right, and have a complete paralysis that occurs on a rather precipitous time scale. So some of these patients may present with a sudden onset and not have a more classic gradual onset. Just be aware and look for those calcified spicules within the tumor to give you a clue on facial nerve hemangioma. And furthermore, on a facial nerve hemangioma, when you do MRI imaging of those lesions, the calcifications are going to appear dark, so you might have some type of void or black spots within that tumor, and that also can clue you into a hemangioma. It's also possible to have metastatic disease. Here are some representative CT scan images of a destructive metastatic lesion from a renal cell carcinoma that presented with rapid onset facial nerve paralysis, complete hearing loss, and profound vertigo, and was subsequently found to be consistent with a metastatic spread of primary renal cell. But that rapid onset of facial nerve paralysis, perhaps even the presence of pain, deep boring pain within the ear, may also raise one's concern for a more malignant process. Cholesteatoma also can injure the facial nerve in a variety of different locations. Cholesteatoma can track along the course of a dehiscent facial nerve through the fallopian canal and actually lead to internal auditory canal pathology or extension of cholesteatoma. However, the cholesteatoma and associated granulation tissue and inflammatory changes can injure the facial nerve at the tympanic segment or the second genu region. So this is certainly a reason to perform CT scan imaging in those patients with chronic separative otitis media and cholesteatoma that might have any signs of facial anomaly. You want to be aware of where the pathology is affecting the facial nerve. And osteodystrophies can also influence cranial nerves, especially the facial nerve. This is some representative images from osteopetrosis, which results in this narrowing of cranial foramina that can cause significant narrowing of the internal auditory canal and compression of the facial nerve. This is a very difficult and complex condition. Decompression may be indicated in this particular situation. Here are some abnormal facial nerve physiology definitions and terms that you might see in management of facial nerve and dealing with facial nerve. So synkinesis specifically is the abnormal synchronization of movement. We often treat this with Botox in those selected areas where the synkinesis is occurring and causing difficulty. One has to be very cautious and careful in the periorbital region of using Botox there because of the risk of exposure keratitis with, over use of Botox in the area. Crocodile tears is the phenomenon of tearing during eating, which is a crisscrossing of parasympathetic fibers within the greater superficial petrosal nerve. Stapedius contraction, which is fullness or roaring in the ear due to stapedial muscle overactivity, and so the tendon can actually be sectioned to address this. Hemifacial spasm of the facial nerve can occur due to compression of the facial nerve by a vessel loop within the internal auditory canal or cerebellopontine angle, such as a branch of the anterior inferior cerebellar artery that can be treated with microvascular decompression. Facial myokymia is another term that you may not be familiar with, but this is a continuous undulating movement described as bag of worms movement, and it's associated with conditions such as multiple sclerosis or brainstem tumors, not likely to be presenting initially to an otolaryngologist, but could possibly. Blepharospasm is also bilateral spasmodic eye closure in the setting of facial nerve injury. These are some references for the things that were discussed in this particular lecture. And I'd like to thank you for your time and attention. It's 5:55. I will end the PowerPoint show here and see first and foremost if there's any questions from those that may be in attendance. I'm certainly happy to entertain those. I also have some surgical videos that I'm happy to share with the few moments that we have left. Dr. Raymond, any thoughts, comments, questions so far?
Great talk, Dr. Bush. Thank you so much again. I have a patient presentation. I don't want to put you on the spot, but one of the pathologies that is under consideration came up, and it's just an interesting case and might spark some discussion. If you're open to that, I'll bring it up and we can chat about it.
Sounds good.
Okay. So this was a middle-aged woman, previously healthy, who came in as a referral with acute onset unilateral facial paralysis and a workup that showed a somewhat expansile lesion in the distal segment of the right facial nerve in the vertical segment coming into the stylomastoid foramen. Further workup, MRI, it looked like a facial schwannoma. At the time, she had what looked like potentially some fluid versus expansion of the lesion into the middle ear, and she had been started on antibiotics and steroids by the referring provider. Well, long story short, the paralysis improved and is now nearly resolved, and it's been some months, and we repeated imaging and the lesion hasn't grown, still presumed to be a schwannoma, and the location is in the distal vertical segment approaching the stylomastoid foramen, just coming into the stylomastoid foramen, but without extension into the parotid. And so, talking about the options that you discussed, and we left it a little bit open-ended with her, but presented her with some options that we would consider. And without giving those away, just wanted to see what your thoughts would be, how you would talk to this patient, and maybe hear from some others too about what their thoughts are.
Yeah, facial nerve pathologies humble the most arrogant and haughty skull-based surgeon because you want to maintain that axiom of first do no harm. We certainly want to first do no harm to the face and the facial nerve itself, knowing how precious and personal facial nerve function is to one's facial appearance and the cosmetics of the facial movements. But also you balance that with first do no harm of, do you have some terrible tumor that's going to take your life? I think if you have some pathology in a region or location that doesn't seem common or likely, you wonder and worry, is there some metastatic disease somewhere else? I would worry about parotid pathology. I'm assuming that the imaging within the lateral skull base and the parotid bed looked normal and looked okay.
Yeah.
You certainly could consider full body PET scan imaging to look for, occult disease from some other location. That would be something I would consider if you're dealing with what seems to be uncommon location, uncommon presentation, and without all of the negatives and the bad things of progression of loss of facial nerve function that move you more towards resection or biopsy. Your hand feels pressed more to observe conservatively, then I think you can justify doing some PET scan imaging. I have had patients that have had difficulty in getting insurance approval without some documented strong history of malignancy. In those situations, I think that you have to make a case and a claim for potential malignancy being within the facial nerve to try to justify it. What was the status of the facial nerve as she resolved clinically? Did repeat imaging show improvement there?
The lesion has stayed the same size. It enhances. It has all the same characteristics, but clinically, she is uh, nearly completely better. She has a very, very subtle lower lip weakness that is really only noticeable to her and her husband. But otherwise, essentially normal facial exam at this point, and it came from a complete paralysis.
Yeah.
So let's say it was about 6 months or so, she improved, which, made us think much less likely malignant and more in
Right.
line with the radiologic diagnosis.
Absolutely. And I think, when you consider, if a patient's saying, look, I really want to know what's going on, I'm fearful, you don't want to be dismissive of those fears. One could consider, a surgical exploration just to further decompress around that area to see if there's any tissue that perhaps doesn't stimulate that you might be able to obtain some kind of biopsy, knowing that any kind of manipulation or biopsy of that area could reintroduce the facial nerve weakness again clinically. But I think that would be an option as well for that patient. Thinking about hemangiomas in that area, could you have some other type of primary, inflammatory condition? It's a possibility, but facial schwannoma probably truly is the most likely situation. It sounds like from what you've described, and I don't know that I would do anything different than other observing uncomfortably, maybe somewhat nervously, but probably continue observation myself. I don't know. Anybody else have any thoughts or anything I missed on the oral board exam question you gave me?
Hey, Mallory and Dr. Bush. This is Nate Cass. Hey, we had a patient that was similar to this, not quite as expansile on the imaging, smaller lesion, and did light up with contrast. It was just very unclear radiologically what this was, and we got together with head and neck, and we did a decompression, and head and neck did a biopsy. And her face was totally out afterwards.
Hmm.
Um, but it eventually came back as adenoid cystic, even though it was literally stylomastoid foramen and superior. There was essentially nothing in the parotid, so it was very strange to us. Didn't see anything in the parotid, so anyways, took her back for a total resection and parotidectomy, and a cable graft. But it was one of those things where preoperatively, I remember I was talking to my co-fellow and we were saying, I don't know that I would do this, but it turned out to be what, you kind of just sit there and talk with other people, like, think about what you do in those shoes. But it was eye-opening to me because I felt like I would have probably made the wrong decision in that case. That's why you get repeat imaging but you lose months to potentially prevent that patient from having a distal metastasis or something. So anyways, that was a good case for me to learn from.
You're right on the money, Dr. Cass. I mean, you further, move that to, do no harm to the face, do no harm to the patient, and you just struggle, with that decision making. And as long as the patient, is with you, and that doggone parotid can do some pretty insidious things, and that's that adenoid cystic's a bad player, and that's exactly what it does. Travel right along the facial nerve.
Hi, Dr. Bush. This is Vivian from OSU. I'm the first year neurology fellow. Thank you so much for this lecture. It was really great. And to piggyback off of Dr. Raymond, we had a case kind of similar that I actually did today, where it was this enhancing facial lesion in multiple segments. But what was odd was that it also kind of had enhancement in the cochlea and also in the posterior semicircular canal. And you could actually see that when we were drilling today. So we sent a frozen off, and it was positive for some spindle cell lesion in the cochlea. So I just wanted to know if you found anything like that where you did see local invasion, and it was very clear also just that it was facial in origin because it was completely along the vertical segment. You had widening expansile lesion there. So yeah, interested to hear your thoughts.
Wow, that's crazy. I mean, so the enhancement was within the cochlea, but all the bones intact. There's not erosion of the otic capsule from the primary lesion.
That's correct. Yeah.
Wow. What about NF2? When you get, a wide range of schwannomas anywhere and everywhere, that makes me nervous about, NF2. Probably the other side is all normal, I'm assuming.
NF2 is definitely a good thought. Her facial nerve had like some enhancement, but it was normal in function, but it wasn't like wide or any mass at all. Of course, we'll continue to observe her, but that's definitely a good thought.
Yeah.
Go ahead. Sorry.
No, go ahead.
I had one more question actually. There was another patient where we were doing a middle ear exploration for what we thought was a glomus tympanicum, and it ended up being more of a tympanic segment, like mass of the facial nerve. But we didn't do anything until we drilled the mastoid and traced everything out and decompressed it, and it indeed was of the facial nerve origin. And then we took a biopsy because it actually was on a pediatric patient. So we were concerned for like a schwannoma, even though the patient didn't have a paralysis. So given that it was a small biopsy, we thought it would be safe. And I was just curious because, like you said, it doesn't cause facial paralysis until later, but the biopsy also didn't cause any paralysis. So is that common that you've seen where, like, in the actual tumor segment, if you take a biopsy, you wouldn't cause paralysis? So it would be safe to continue that approach?
Well, you did that on a kid, and seems like things tend to always go better with kids when you do the exact same thing. I have really only done that with adults as far as biopsying, and it's probably been about 50-50 as far as, if there's been as far as either progression or worsening of where they were, either from normal to some degree of weakness or from some degree of weakness to worse weakness. But with adults, I've seen it about 50-50. It does depend on the pathology that you're dealing with. I mean, sometimes it's just a really prominent nerve that's kind of overhanging, its boundaries. But, those schwannomas right in the tympanic segment, I find that you can get a little biopsy in that area in adults, and get away with it. But you just got to be, that's the number I keep in my brain, about 50-50. But I don't know any data regarding children, but, difficult, uncommon condition to see, to have an adequate number to really give you, counseling advice for patients.
Great. Thanks so much.
Great questions. You guys are making me sweat. It's at the end of the day. This nerve group is for real.
Dr. Bush, how often or how early do you get a facial nerve rehabilitative surgeon on board, like facial plastics?
As soon as possible, really. It's just like having conversations with your biostatistician. When you begin to set up a research study or clinical trial, the sooner the better. You never want someone saying, well, I wish you'd talked to me before you left that smoking hole in the skull base or what have you. But the reality is I think the patients really, really appreciate that. So any kind of facial nerve pathology, the sooner that you can make a connection, that patients feel and understand that we're going to manage this as a team, with you being the center of this team in a transdisciplinary fashion. So it's not necessarily on the exact same day that I see them for an initial consult, but if it's a patient that was in the hospital that's going to follow up, I want to try to arrange that on the same day as seeing one of our facial plastic surgeons. But the same thing, then, after I've seen them for initial consult, set up that next visit when they're seeing me to see one of my colleagues, and even to see them together in the same room. I know that seems like, an impossibility, but if you can get those planets to align, patients really, really like that. They just love having two people that are going to listen, that are going to help them work through this functionally, original pathology function-wise, hearing function, and then cosmetics. They really appreciate that.
Okay, thanks. I heard I don't know if you heard any of this at Academy, but there was maybe it was COSM last year, but there was somebody in New York who essentially was starting to do some basically 5/7, 12/7 transfers for some of these before resection, so that essentially as the nerve fibers were atrophying, they were capturing those fibers, the motor end plates, prior to the facial nerve schwannoma taking it out. So I don't know if you've ever done that, but that seemed very interesting to me. I'm not sure that I would necessarily do that, but just curious to hear your thoughts.
Yeah, it is very interesting. I haven't been a major champion for any 5/7, nerve transposition, just because of taking one cranial neuropathy and exchanging it for 1.5 or 2 full cranial neuropathies. So I've been less involved in that kind of work, cable grafting, and then, wide use of other mechanisms, in the armamentarium of the facial plastic surgeon, and, whether that's free tissue transfer or what have you to further address things. But that's a pretty innovative, good idea. I think it makes sense, physiologically, to try to help get the nerve as much input so that the loss of function, is minimized as much as possible.
Thank you.
Good stuff.
Thanks again, Dr. Bush. This was great, and we appreciate you being put in the spot for all of our questions.
I'm going to send all of my facial nerve pathology to all you all. So just you wait. It's all coming your way. Compliments of the Commonwealth of Kentucky. Good to hear everybody's voices, and good appreciate attendance, and I can't wait to see you all in person sometime soon. We'll see.
Sounds good. Take care, everybody.
Thanks.